So heart blocks, they were talking about the AV node being suppressed for some reason. So it's suppressed by drugs, it's suppressed by ischemia, it's suppressed by, what else? About scar tissue, maybe electrolytes might play a role. So we're talking about AV blockade, and you can describe it in 3 different degrees, and one of the degrees has 2 types. So 1, 2, 3, 4 types of AV blocks you have to know, right? So we have the first degree AV block, which is your most simple one, just means that one of your intervals is prolonged. Which interval is that? What interval talks about your AV node? The PR interval, right? Not the QRS, but the PR interval. So the PR interval, this guy right here, is prolonged. And what's a normal PR interval? We don't care what the low one is, right? Unless you're worried about Wolff, Parkinson, White. We're worried about what the prolonged one is, right? What's the high amount? What's the high end? 20, right? So greater than 0.20 equals a AV block until proven otherwise, right? And usually it's an AV block. If your PR interval is more than 0.20, that's a problem. If it's more than 0.24, you're definitely not giving any kind of AV blockading agents. So that's the reason why we're going over this, because you have a lot of medications we give that are going to prolong your AV node, right? Which agents are those? What are some drugs that might prolong the PR interval? It's the A, B, C, D drugs, right? So A for what? Amiodarone does a little bit. B for beta blockers for sure. C for calcium blockers, which flavor? The non-DHP one, which is only 2, right? Your verapamil and diltiazem. Those are the only 2 that will prolong your PR interval. The other beta blockers we give for hypertension, they have no effect on the AV node or heart rate, right? They cause reflexive tachycardia because of the blood pressure being too low. And we've got C for calcium blockers, and we've got D for Dig or digoxin or digitalis or digi something, right? Digibind is the antidote for digoxin, right? Anyways, we got a PR interval that's prolonged. If you keep giving those medications because you didn't notice, oops, I forgot, I got 4 patients, I got 75 meds to give. I didn't realize that was going to prolong my PR interval. Now you're going to go into a second degree block, most likely, right? Maybe it was your fault, maybe it was iatrogenic, meaning it's like, oops, I did it, or it was because of the patient took too much other medication at home, right? They took too many of their beta blocker pills, too much of the digoxin pills, or they're taking their digoxin for years and now they developed acute kidney injury or chronic kidney disease because of their their long-standing diabetes or hypertension, and that could be the reason why they're dig toxic. Anyways, we're going to talk about secondary blocks. The nice thing about secondary blocks, you just look at them, they're always irregular. Why are they irregular? Because there's a complex that's dropped, right? These guys are first degree blocks were always nice and even, right? Nice and regular rhythms. That's one way to tell the difference. The first degree blocks are always regular. Second degree blocks are always irregular. Another thing, going to third degree blocks, third degree blocks are always regular as well because they're divorced. They're doing their own thing. And we'll talk about that. Okay, so those are atrioventricular blocks or AV node blockade. So a little table up in the corner here kind of summarizes everything we're going to talk about with AV blocks, right? So again, we have a blockade of the AV node. PR interval is greater than how much? 0.20, right? The signal is delayed or cannot get through. So here's our AV node right there, SA node up top, and our AV node is blocked for some reason. There's something in the way, right? And it's basically an extension of bradycardia, right? So bradycardia causes what causes you to get bradycardic? For some reason you were about to die, right? So you had some drugs, such as A, B, C, D drugs, right? You had ischemia, or you had electrolytes, right? An extension of that can progress to sinus bradycardia. Sinus bradycardia can progress to like PEA, asystole, or it can progress to an AV block, right? So again, AV blocks have a first degree variety, second degree, and third degree. And we'll talk about the different types of second degree. Wenckebach and Mobitz 2, that doesn't really make any sense to me. I always had to kind of figure it out. It's like, well, which one is it? Is it Wenckebach or not? It doesn't make any sense. Either way, we'll go over these. And as we mentioned on the title slide, we had which ones are regular, our first degree and third degree. So that's nice. When you put it in table form, you can easily see what is good and what is bad, right? You can see what is regular, what is irregular. You can see which ones have dropped QRSs, right? And those were our second degrees. And if we have a regular rhythm and we drop some QRSs randomly, that rhythm now becomes irregular, right? And if you notice, the PR interval is always prolonged, okay? Sometimes there are some exceptions, like secondary type 2. Sometimes it'll be abnormal. Sorry, it might be a normal PR interval, but it is, for the most part, if your PR interval is greater than 0.20, you have an AV block on your hands. And if you keep taking the beta blockers, you keep taking, things that are going to make you die. You keep getting more ischemic. You keep getting more electrolyte imbalances. Your K keeps going up. Your MAG keeps going up. These things can make you even more bradycardic, right? And we're going to touch on that. That's where you start getting junctional blocks. That's the next step beyond AV blocks, right? Those are overachievers. Those are ones that are going to go above and beyond and become even more blockade, where we're going to all the way be down there at the junction, right? The junction between the AV node and the His fibers, right? And then after that, after everything else goes down, right, then we're going to have a junctional block. Sorry, junctional block, idioventricular block. I'm trying to figure a different color. There we go, idioventricular blocks, right? And that's where you're all the way down there in the His Purkinje system, and you're not involved in the AV node at all, right? The ventricles are the last effort to give you a heart rate and blood pressure. Okay, and we'll talk about junctional rhythms and idioventricular rhythms shortly. Okay, bundle branch blocks you may have heard of. Bundle branch blocks are due to prolonged what interval? What interval is prolonged in that case? The QRS is prolonged in bundle branch blocks. That's with QRS stuff, right? So bundle branch blocks is just QRS being prolonged, greater than 0.12, for instance. Right, so that one we're not worried about. Bundle branch blocks you can ask in clinical. You can ask your clinical instructor to show you what bundle branch blocks look, how to figure if it's right or left and such, but that's not something we're going to be worried about or testing on. Okay, so the cause, there's our ABCD meds, right? ABCD meds, drugs, ischemia, or electrolytes, and the treatment is the same as sinus Brady. And what was the treatment for sinus Brady? Atropine is going to work for AV blocks pretty much until you get to a second degree type 2. Then it's probably not going to work great, right? So we're going to add another column to this chart. I'd write down what the treatments would be, right? And atropine is not going to work at second degree type 2s and third degree AV blocks. Basically, your AV node is done at that point. Is too far gone, right? Given atropine, what does atropine do? It's an anticholinergic, right? It's going to upregulate the SNS or the accelerator, and it's going to increase the activity right there on the AV node, and kind of stimulate it by promoting the SNS fibers on that AV node. But if that AV node is so far gone, right, in a second degree type 2 or a third degree AV block, it's not going to respond. It's not going to work, right? So atropine is really not going to work towards when you start getting the third degree blocks, especially, right? Secondary type 2s, maybe you can give it a try. Let's, YOLO, let's go for it, right? But otherwise, it's not going to do much, right? It's definitely not going to do anything for junctional. It's definitely not going to do anything for idioventricular blocks. Okay, so the treatment, same as sinus Brady. Atropine is on the list. What else do we got? You can pacemaker, right? We do have some other few things in the back pocket. We can do epinephrine, which also is going to work on the AV nodes. We have, isoproterenol can work as well as an infusion. But basically, you got to switch over to pacing the patient, right? They have to be paced. So we'll talk about pacers in detail, right? So that's your transcutaneous pacing, transvenous pacing, and even a permanent pacemaker eventually. Okay, and then these guys get symptomatic, right? So what are the symptoms of any EKG ever? Chest pain, shortness of breath, hypotension, confusion. Any one of those things is any other EKG, right? When an EKG gets symptomatic, they get chest pain because there's no flow to the heart. They get shortness of breath. There's no flow to the lungs you can think of, and also the heart's going to fail and it's going to pump. The fluid is going to back up in the lungs. And then what's next? Hypotension, right? Because you're not putting out enough blood pressure. The blood pressure is made by heart rate times stroke volume, right? Each stroke is not that, it might get enough volume, might be 70 cc's, 100 cc's, but the heart rate is a big component of that, right? That's your cardiac output, is heart rate times stroke volume. So you're going to have a low blood pressure because your heart rate's low. And then what's the last thing? You get altered, right? Why are you altered? Because you're not getting flow to your brain. Okay, so those are the symptoms of every EKG, including bradyarrhythmias, right? Whether it be junctional, third degree, type 2, secondary type 2, secondary type 1, it doesn't matter. You're going to get a poor cardiac output in the end. That's the worst case scenario. That's always what, as a nurse, we're going to be looking out for. Do you have any chest pain? Do you have any shortness of breath? Do you have any, are you confused? I'm not confused, right? So no, you're going to assess if they're confused, right? You're going to assess their blood pressure, assess their vital signs. And the next step after that is always to get a what? EKG, right? Especially a 12-lead EKG. It's going to tell us a little more information about what's going on, right? So that's the interventions for every arrhythmia out there, okay? So again, AV node suppressing agents could be the reason why we have this happening, right? We got drugs, electrolyte imbalances, ischemia. We have AV node dysfunction, AV node overactivity, right? And we get a AV block of some sort. And it's sometimes asymptomatic until you put them on the monitor. It's like, whoa, that looks pretty funky. You said you've been feeling fatigued for the last week. Well, why are they fatigued? They're not getting blood flow to their muscles, right? So that's why they're feeling fatigued, right? So then, but when they start getting symptomatic, that is where you are very, very concerned. When they have chest pain, right? Shortness of breath, hypotension, or confusion. So we'll talk about each block individually. So first degree AV blocks, again, all you have is a PR greater than 0.20, and that's it. There's an option for certain blocks to have a dropped QRS, right? This is not one of those. Which blocks have dropped QRSs? Second degree type 1 and second degree type 2. Second degrees have dropped QRSs, and because of that, those second degrees are irregular. This is just a regular rhythm just going along, and it just has a long PR interval. That's the only thing that's going on with this rhythm, right? And that's the idea with a prolonged PR interval is you have a risk for first degree block or second degree or even third degree. And how you tell the difference? Well, it's a regular rhythm for one, and there's no dropped QRSs. That's why I have a regular rhythm, right? But you can also have regular rhythms with which other block? Third degree. So that's why we then differentiate. Do I got a first degree or third degree on my hands, right? Basically, for first degree, I'm still married. I still have a P, right? Followed by a QRS. That's the normal progression of things. P, QRS, P, QRS. Whereas when we talk about third degrees, it's not like that anymore. It's their P is doing its own thing and QRS is doing its own thing. They're not any kind of relationship at all. Okay? So the rhythm will be regular, right? And one big box is is 5 small boxes, right? And one big box equals how many seconds? 5 small boxes, of course, right? And 5 small boxes is 0.04 for each small box. So 5 times 0.04 is 0.20, right? So anytime your P wave is bigger than your box, right? There's my QRS. That is guaranteed a AV block of any sort, right? So that's one quick way to identify if someone has a block of some sort, right? So again, no dropped QRSs. If they have dropped QRSs or drop beats, which kind of block is that? That's a second degree block, right? And then we investigate further as a type 1 or type 2, okay? All right, so caution giving AV node suppressing agents because you're going to make that PR interval more prolonged, right? So sometimes your PR interval will be 0.22, and then they'll say, go ahead and give the medication. The risks outweigh the benefits, right? But you're going to keep an eye on them to make sure it's not going to get even more prolonged, right? So when you go to the hospital, most of your patients are on telemetry monitoring. They have EKGs in place, and we can monitor if they have a prolonged PR interval or not, right? That's something you should be reporting to your clinical instructors, saying my PR interval is this before I give my metoprolol, which is one of my ABCD drugs, right? One of my beta blockers. All right, so calcineurin blockers and digoxin. And specifically, we said it was the non-DHPs. And if you know the difference between DHP and non-DHP, we talked about that at the beginning of EKGs, right? But we're talking about non-DHPs. That's supposed to be saying non, right? So what is a non-DHP? That's your verapamil and diltiazem, right? Or DILT, right? So those are your only two that will lower your heart rate. The other ones raise the heart rate, all right? So these usually are asymptomatic. They don't usually recognize that. You're not going to say, oh, I got a first degree AV block, right? That's not something that a patient's going to recognize. They're going to start recognizing it when they are getting to a second degree block or a third degree block. They're going to be a lot more symptomatic as the blocks progress. So second degree blocks always have a dropped QRS or EK or one of the complexes, the QRS complex is dropped, right? It's missing, right? It's on the back of milk carton somewhere. So let's draw a little milk carton right there, right? So have you seen me, right? It looks sad too. Right, so you've lost a QRS. The QRS is gone, right? So it happened all of a sudden, basically, right? With type 1 blocks, you can see it coming. So you can see the PR interval is, might be okay. Then you got a PR interval that starts getting prolonged. Oh, that's curious. Got a PR interval greater than 0.20. You might have a first degree AV block. But this PR interval then gets longer. So if it gets longer, and then drops, that is a second degree type 1 block, right? So PR interval it could be normal, but we're not going to make it complicated like that. And on the test, I'm not going to give you normal PR intervals. They're going to be obviously prolonged PR intervals, right? You're going to see EKGs complexes that are dropped, and specifically the QRS interval. The QRS will be dropped in this case. And here we saw getting longer, and dropped is a characteristic of second degree type 1 blocks. And it's actually pretty rare. When you see it, it's like seeing a little unicorn. It's like, oh, look at this, that's cute, right? Or like a double rainbow at least, right? Because unicorns aren't real. So anyways, unfortunately. So yeah, that's the idea with second degree type 1 blocks, is that you have a higher grade block, obviously, their first degree AV block. Someone wasn't paying attention, or they came in, and this is when they started getting symptomatic. I feel really fatigued. I feel really, short of breath the last, 5 days or so. So you'll see a PR interval that's getting longer, and then all of a sudden you get a dropped QRS. And that's gonna make my rhythm regular or irregular? Irregular, right? Because there's a drop beat. It was nice and regular until this guy happened right there, right? I had a dropped QRS complex, right? So also it's irregular because the PR interval is longer. That's going to make it irregular just by default, right? But we know all second degree blocks, type 1 or type 2s, are going to have a irregular rhythm presentation. And also the characteristics of second degree type 1 and type 2s are that they have dropped QRS complexes. They have dropped beats, right? That's only second degree AV blocks, right? First degree and third degrees, those are regular rhythms. They have all the QRSs are where they expected to be. Okay, so drop QRSs are only a feature of second degree type 1 and type 2. It's like, don't get confused because it's getting a little more hierarchical, right? Like second degree type 1, was that first degree? No. The degrees happen first, and then the types happen next, right? And only the second degrees have types. There isn't like a type 1, type 2 first degree, and a type 1, type 2 third degree. It doesn't get that complicated, unfortunately. Not unfortunately, fortunately. Okay, so longer drop, you have a Wenkebach as the poem people memorize, but then you're like, well, Wenkebach, was that type 1 or type 2? That doesn't really help us too much, but it's a way to figure out which one's which. If you can connect Wenkebach with the first one, right, with secondary type 1, then that can help you. All right, so second degree AV blocks type 2, right? These are your Mobitz 2s. Yes, the other one was a Mobitz 1 technically. Right, but second degree AV blocks we know by default are irregular and they have dropped QRSs, right? So it's like, was that the end of the story? Well, how did that tell a difference between a type 1 and type 2? A second degree type 1 and a second degree type 2, not a first degree. We're talking about just second degrees right now, right? So these guys are going to have a irregular rhythm, so what's different? And they both have dropped QRSs. The thing that's different is you do not see it coming. So in the first the first types are secondary type 1s, right? We were able to see it coming. We saw longer dropped. Sometimes it's just one, two longers, longer drop. You can't predict it. Or sometimes like 3 longers. It's longer, even longer, and then it drops. Whereas here it's just doing its thing. PR interval is the same. So it's same Z, and then all of a sudden I have a dropped QRS, right? So we had a same Z, and we got a dropped QRS twice in a row. That's bad, right? I just have a dropped QRS with really same PR intervals, right? They're all the same, all equal, but I have a dropped QRS, right? So the only difference between type 1 and type 2 second degrees is the PR interval is either the same or it's prolonged. Not prolonged, same or longer, right? Little asterisk there because all AV blocks usually have prolonged PR intervals, right? But there can be a little asterisk here where these guys can have normal ones. But again, on the test, I'm not going to give you ones that are going to have a normal PR interval. I want you to think prolonged PR interval is an AV block. And the next step is, which one is it? Okay, so PR interval is 0.20, but it doesn't change, right? Yes, it's sometimes normal, so in real life you'll see a normal one sometimes, but if you have a prolonged PR interval and you have a drop QRS, which is going to make your rhythm regular or irregular. To make it irregular, right? You're going to have irregular rhythms. You have a rhythm like has that's irregular. I can just look at it from afar and see that, well, there's something missing there, right? There's something going on. Do they have AFib? Because usually when you say irregular rhythm, the first thing, most common rhythm arrhythmia out there is AFib. So that's the first thing you think of. We're like, oh shoot, there's P waves. Oh shoot, there's PR intervals. Are there PR intervals in AFib? No, there's no PR intervals in AFib because there's no P waves, right? There's fib waves, right? So I got a PR interval and I have drop complexes. Then you have a irregular rhythm with P waves. Now you're thinking of a AV block mostly, okay? And there can be other things like PACs and other things that could cause it to, cause you have an irregular rhythm. Either way, going back to secondary type 2 blocks, right? These guys have it's a very, very higher grade block, right? We've progressed from first degree to secondary type 1. Now we're on secondary type 2. And we're dropping QRSs randomly. That's not good, right? The causes were just the same as every other sinus Brady or other bradyarrhythmia. We have drugs, ischemia, electrolytes. There's something going on that's suppressing my AV node. Okay, does that make sense? Any questions on how that works? So the next step after that is obviously a further progression of this, a further destruction of our AV node, whether it be like ischemia or a further inhibition of my AV node, whether it be drugs, and that's going to be a third degree AV block, right? So a third degree AV block, right? Our AV node is completely blocked, right? There is nothing getting through. Okay, so since there's nothing's getting through, the fibers down here are like, what the heck? Where's my P wave at? I'm expecting a P wave. So I guess I have to do things myself, right? So it's going to do things itself at that point. So you're going to see the ventricular activity doing its own thing and the atrial activity doing its own thing. And what's atrial activity? P waves. And what's ventricular activity? QRSs. They're going to be like really weird QRSs. They're going to be super wide, right? And that'll make sense when we talk about idioventricular rhythms, because idioventricular rhythms are wide because they come from the ventricles, right? So any rhythm that comes to the ventricle is wide. If it went through the normal pathways, the normal highways through the whole heart, then it's going to be a narrow complex. Yeah, with a little caveat. If it's a bundle branch block, yeah, it could be wide too. We're not going to get complicated like that. Okay, so the AV node is completely blocked. We're completely shut off from the atria. Okay. So this is usually symptomatic. This is not something that you can just walk around with. You're definitely going to be symptomatic at this point, and you probably need a pacemaker to get this fixed until we can figure out what happened. Did you overdose on beta blockers? We can give reversal agents for beta blockers. What's the reversal agent for beta blockers? Glucagon, right? Glucagon is going to be the reversal agent for beta blockers and also for low sugars. And what else? So you got A, B, C, D drugs. Glucagon is for this one and this one, right? Glucagon is going to make the beta blockers go gone and make the calcium blockers go gone too, right? So those are the reversal agents. That is a reversal agent for beta blockers and for our calcium blockers. And then what's the reversal agent for digoxin? Digibind, right? Or digoxin immune fab if you are fancy, right? So those are the ways we can say, well, you have a third degree block maybe because you took too many medications. That might have been what happened, right? Ironically, they could get confused because they have a low heart rate and then take too much of the medications and make it worse, right? So we always have to figure out what's the underlying problem. We do a 12-lead EKG because it'll tell us what is going on, but also it could uncover that they might have ischemia, and that's the reason for the third degree block in the first place, right? So there's AV dissociation, right? So AV dissociation, that means they are divorced. It's a fancy way of saying we are now disassociated, right? So you tell your boyfriend we're disassociated now, right? So that means that you are now separated, okay? You're doing your own thing now. So the P waves are doing their own thing and the QRSs are doing their own thing. So you can see here's the P wave doing its own thing. It has its own rate and it's beating to its own drum, literally 60 to 100 beats per minute because that's what P waves do, right? And then we have a QRS doing its own thing as well. Let's do a different color, right? You got a QRS is doing its own thing. right? There, is doing its own thing as well. And it's nice and wide like that because it came from the ventricles. And if you put it all together, you're going to see this third degree AV block on the bottom. You're going to see P waves after the QRS, you know, right like on top of T waves. Like what the heck's going on? You're going to see a P wave right in the middle of an ST segment. Why is that happening? Because it's doing its own thing. And it's contributing electroactivity because we're depolarizing cells, right? And you got a P wave like, oh, look at that, it's not a prolonged PR interval at all. That's a perfect one. But you look at the one, if you try to like march it out with your calipers that you bought in first semester, right? Then you can see that the P waves are doing their own thing. It's not P wave QRS, P wave QRS, right? It's a regular rhythm, and so is a first degree AV block. The only difference between first degree and third degree AV blocks is what? That they are, one's associated and one is disassociated. One is married and one is divorced. Okay, so which one's divorced? Third degree AV block, right? They are they're doing their own thing, and you'll see that. You'll see, oh, look at that. The QRSs are doing their own thing. It's different from my P waves. So technically, your P wave or your P to P interval and your R to R interval are different. Because what's the R to R interval? R to R is your, yes, it's your heart rate, but it's your technically your QRSs, right? And your P to P interval over here is going to be different as well. That's something, another way to trick to figure out if they have a third degree AV block or not, right? So there's not a QRS following every P wave. That's how you know they are disassociated, right? You can march them out. You can see that the P to P and R to R intervals are different because in a regular rhythm, they are going to be exactly the same because it's P QRS, P QRS, P QRS. And usually we just use the R to R interval because we know they're associated normally, okay? So QRS is usually wide because it came from the ventricles. That's a big clue that you have a third degree AV block. You have a wide QRS, it's regular, and it is disassociated from the atria. Meaning, how do we know it's disassociated from the atria? Because the atria produce P waves and the ventricles produce what? QRSs, right? So that's third degree AV blocks. So then there's a little summary of all the different AV blocks we've just been talking about. So we have our little table here, right? You can add on treatments on the side over there, what our treatments are. Usually we're going to give what first? Atropine. We'll try atropine. And usually it's not going to be effective once you start getting down to secondary type 2s, and definitely not effective when you have third degree AV block, because third degree AV blocks means that we have no AV node activity. Okay? So we have a next thing we have to do is what? We have to then start pacing them, right? So pace. So when you look at first degree, second degree, third degree blocks, you can memorize it, and you can memorize that table, but the best way to look at this is algorithmically, meaning that you have to memorize this algorithm right here. If you can write this algorithm out 3 times, 5 times, 10 times without looking, then you know your AV blocks inside and out, right? That's going to help you understand them, because there's just so many variables here, right? Was it regular or irregular? Was it prolonged or not prolonged? Was it longer or not longer? Was it associated or not associated? So that's the benefit of having an algorithm, is that it clearly spells out exactly what pathway we're going down. Okay, so if you look at PR interval greater than 0.20, you have an AV block until proven otherwise, right? And yes, you can push up your glasses and say, well, but secondary type 2s might have a normal PR interval. But we're talking about the majority of the time. You're going to have a prolonged PR interval with your blocks here, right? So the next thing I'm going to look at after I say, is there a PR interval that's prolonged, is there drop beats or not? Because if I have drop beats, what kind of AV block do I have? I have a second degree, right? So then I'm going on the second degree part, and I'm looking at, is it longer? That's a which one? That's a second degree type. So we're in second degree territory over here. We're in second degree territory, right? So I have a second degree type 1 if I have longer and dropped, right? If I have drop beats and the PR interval is the same every single time, what is that? That's second degree type 2. And yes, PR could be normal in that case. You're just saying the normal like sinus rhythm. Whoa, they just dropped a QRS. Look, they did it again. All right, that's a second degree type 2. Okay, so then going back to talk about the other guys, right? Because we took care of second degrees. What about third degrees? Third degrees and first degrees. So your PR interval is prolonged, right? We got a PR interval that's prolonged, greater than 0.20. Right, that means you have a first degree or third degree. The next step is their drop beats. Do we have drop beats in first degrees and third degrees? That's a no. So the next thing is you ask yourself, is this PR interval ridiculous? That means that you got a PR interval of 0.40 or 0.62, 0.84, right? That's a ridiculous PR interval. There's a point where he's like, well, let's keep going. It's 2 boxes wide or 2 big boxes wide. It's like 0.40, 0.54. So if it's ridiculous, you got a third degree AV block in your hands, right? The other way to confirm that is you can say, is there AV dissociation or not, right? Are they divorced? Another way to confirm that is, are they have wide QRSs? That really kind of clues me in. They got to have a third degree too. Okay, so PR interval is ridiculous, right? It's a ridiculous PR interval. If you look at them, they are gonna, we'll do some practice here, you're gonna see that they are extremely long. It's like, what the heck? Why is on PR interval 0.62, right? So if it's not ridiculous, then it's a first degree AV block, right? That means what? That means I had a PR interval that's prolonged, I had no drop beats, and I have a PR interval that's not ridiculous, right? A PR interval that's 0.26, right? It's 0.28 maybe. You can have PR intervals that are 0.40 with first degree AV blocks, but you have AV association. In those ones, you have PQRS, PQRS. And usually when it's PQRS, that means usually my QRS is going to be narrow, right? So does it make sense for AV blocks? That's how they work. That's how it happens. Okay? And yes, there's a cute poem, but the poem's not going to really tell you which one's which. If you can memorize which one's Wenkebach, then your poem is going to make sense to you, right? So when none of the P's when none of the P waves are blocked, it's a first degree block. When some are blocked, it's a second degree block. When all the P waves are blocked, it's a third degree block. But what's the actual poem? If the R is far from the P, then you have a first degree, longer drop, and it's a Wenkebach. And if some P's don't get through, I mean, that's a Mobitz 2. And if P and Q's don't agree, that's a third degree. They are disassociated completely. Okay? So the poem can make sense, but you got to, kind of think about it rationally. What do I have here? I have an irregular rhythm. Do I have a PR interval that's prolonged or not prolonged? Do I have dropped QRSs or not? All right, so what's number 1? What's going on there? So I'm going to line up a guy that's right on the box, because that's usually what I'm looking for when I'm looking at intervals, and that's going to make it super easy. And I can see that it is longer. Well, I can't draw a straight line right now. I have too much caffeine on board, right? So that was a perfectly straight line right there. All right, but you can see that it's longer than a big box, right? Can you see that? That is longer than a big box. So if it's longer than a big box, that means a big box is how long? 0.20. So it's greater than 0.20, so that means I have a AV block in my hands. The next step I look at, is it regular or irregular? Or I look to see if there's drop QRSs or not. That's the same thing, right? So is there drop QRSs? No. So that means it's either a first degree or third degree. So is it first or third? How do I tell the difference? First degree blocks have P followed by QRS, P, QRS, P, QRSs. The P to P and the R to R interval technically are the same, right? So I got P, QRS, I got P, QRS, I got P, QRS, P, QRS. That's looking a lot like a what? A first degree AV block. And first degree AV blocks and second degree AV blocks, those are flavors of rhythms, right? You technically don't just have a first degree AV block. A first degree AV block is attached to another rhythm. So I have a sinus tach with first degree AV block. I have a sinus Brady with a first degree AV block. I have a what else? I have a multifocal atrial tachycardia with first degree AV block, right? So they are flavors. They are not just their own thing. So when you submit your EKG worksheet, it is wrong to say first degree AV block. That is not a complete thing. It's like ordering food from like ordering pizza from the pizza restaurant. It's like, I would like some meatballs. It's like, what do you want? Meatball pizza? You want a supreme? What do you want? Meatball, right? So that doesn't make any sense, right? Or you go to order, say, I want salsa from the taco stop. It's like, salsa. Do you want which carnita? Do you want carnitas? Do you want what do you want, right? So you have to order the whole taco first, and then you add on all your ingredients after that. And one of the ingredients is a first degree AV block. And we can add other ingredients too. We can add PVCs and PACs. We can add a bundle branch block to this as well, right? That's the complete story. So this is just one of your flavors you can add to your rhythms. So what's number 2?
First degree.
First degree, how do you know?
Prolonged.
You're going to line this up with a box. That guy works right there. Is that longer than one big box? That's for sure one. It's almost getting up to 2 boxes. I can't draw straight lines to save my life right now. All right, but you can see that that is a prolonged PR interval. Do they agree? P wave and QRSs? Yeah, I got P wave followed by QRS, P wave followed by QRS. There's no P waves buried inside of a QRS complex or buried inside of an ST segment or on top of a T wave. They're not in weird places. Okay, so that's a what? Sinus Brady, sinus rhythm, sinus tach. Looks like sinus rhythm with a first degree AV block, right? But number 3, what's that? So I got PQRS, PQRS. So they look like they're associated. I got a PR interval that's ridiculous, but is this a regular rhythm? I mean, it looks like something's dropped there. It looks like there's something missing, right? Doesn't it? It looks irregular, just like if you like squint and you close your eyes a little bit, and you can see that it doesn't look nice and regular like the top 2, right? So if I have an irregular rhythm, I automatically have what? A second degree block, right? Now I got to figure out which one it is, type 1 or type 2. So how do you tell the difference? So one has consistent PR intervals, and one has PR intervals that get longer, 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 and then there's a drop. So maybe this one right here was the longest one, right? So let's put an arrow instead. So I got a PR interval of 1.5 big boxes. I got a PR interval that's like 2.5 big boxes, and I got a PR interval that's almost like 3 boxes. And then probably over here we're gonna have another drop, right? So the drop was here and here, right? Drop the beat, literally like EDM, right? So it's going to be a dropped QRS, right? Dropped QRS automatically means a second degree block of some sort, right? So I have a what? Second degree type 1 or 2? Second degree type 1 block, right? And again, this is flavor on top of our regular rhythms, right? And really, we start getting to second degree type 2 blocks, that's when you're going to start saying that it's probably going to progress to a third degree, which is its own thing. The third degree AV block is its own major thing that's not a feature of a sinus rhythm or a feature of a sinus Brady anymore. All right, so we got, I put third degree there, so let's change the story on that. So that's going to be, I'm not convinced. So we're going to put a second degree type what? Type 1. Okay. So yeah, I don't think that's correct. All right. So what about number 4? So I'm going to try to line up one of these guys on a box somewhere, but I can just, if I'm trying to line it up, I can just already see it's greater than 1 box, right? So it's definitely greater than 0.20. So if it's greater than 0.20, it's definitely a AV block of some sort. And if I just look at that and squint, is that regular or irregular? Looks irregular. Looks like there's a drop complex somewhere, right? So if I look at the PR interval, is that getting longer? Yeah. That's definitely getting longer there, right? And then we have a dropped QRS complex right there. So that's going to be the same thing, right? It's a second degree type 1, okay? And then what about number 5? So you got P wave QRS, you got P wave nothing. I got, what is going on? Why is a P wave after the QRS segment? Are they associated or disassociated? They're disassociated. Also, if I measure this PR interval right here, that is ridiculous, right? That is 1, 2, 3 boxes at least, right? That's 0.60 at least. That is a ridiculous PR interval. If I have a ridiculous PR interval, automatically I'm thinking third degree, and I'm going to confirm that by saying, yep, that P wave is not where it should be. It's inside of the ST segment, right? So so you can also see like it added positivity to that T wave. It was like right there on that T wave as well. All right, so that is a what kind of block? Third degree AV block. Okay, so why is that off? But anyways, what's number 6? So there's a third degree up here. So what's this guy right here? Well, I got P wave QRS. Do have a Y QRS, and you think Y QRSs usually are third degrees, but I got P QRS. They're kind of doing, are they their own thing or not?
Third degree.
So this one's like almost third degree. This is a more complicated one. It looks like a second degree type 2, but because there's P drop QRS, and then it's basically going to be doing its own thing very, very shortly. So it's kind of on the cusp of being a third degree AV block. So yeah, so third degree for that one too. All right, so yeah, so we'll just say third degree for both, right? Third degree block for this guy and for this guy. So we're off by a little bit. So spoiler, what's number 7? Let's rationalize it. Why is it third degree? Look at that PR interval. That is ridiculous. Right? So that's a problem, right? That PR interval is what, 1, 2, 3 boxes at least, 0.60. So then we can also see that they are divorced, right? There's P wave and nothing happened. Well, did it drop? Well, if it dropped, I would have a irregular or regular rhythm. I would have an irregular rhythm. Does that look irregular to you? Looks ridiculous, but it doesn't look irregular if I kind of space it out here, right? That is nice and even. Okay, that's perfectly even. So that's either a first degree or a third degree block when it's regular rhythms. So I can say it's a third degree because they are divorced. Okay. Also, I can say the third degree because the PR interval is ridiculous. All right, what's number 8? First degree. Even tells me it's 0.31, right? Do I have any drop QRSs? That looks beautiful. That's super regular. That is not a second degree block at all, right? And are they divorced? No, it's PQRS, PQRS, PQRS. So that is a first degree AV block. Is it sinus rhythm, sinus Brady, sinus tach? Sinus rhythm with a first degree AV block. What about number 9? These are kind of spoiling it here. This is getting PR intervals that are getting longer, and then what happened? Dropped. Can you see how this is irregular compared to the one right above, right? So it's getting longer, and then that's an irregular rhythm. So then what about number 10? What's happening there? And we got P waves with QRSs. P wave, QRS, P wave, QRS. P wave's not longer than, it's actually, it's more than one big box, isn't it? Or just right there at 0.20, maybe 0.20567, right? It's a prolonged PR interval. And I have, is it look like irregular or irregular? That's irregular. If it's irregular and prolonged PR interval, what do I got? It's second degree, but is it type 1 or type 2? So type 1s have longer dropped. Is that what we're seeing here? Those PR intervals, if you measure them all out, they are all the same. So what I have here is drop QRSs, right? Drop QRS right there. I got drop QRS right there, one right there. This is making its way towards a third degree block, but it's a second degree type 2, which is the natural progression. It goes first degree, second degree, third degree, right? So that's a sinus Brady with a second degree AV block type. This is incorrect. That is a type 2. Well, definitely something is missing, right? So that means definitely a what kind of block? Second degree of some sort. So we got to figure out if it's type 1 or type 2. Those little PR interval measurements are they even or are they getting longer drop? What is it? Looks pretty even, right? So if it's an even PR interval, it's greater than 0.20. We know if we have an irregular rhythm. It's a second degree type 2. Okay. And then what about number 12? So they measure the PR intervals for us, right? And then we have a drop QRS complex. So I thought wide QRSs meant third degree blocks. Not always. This person could have a bundle branch block on top of their AV block. So we're not getting into bundle branch blocks, but you know that bundle branch blocks can be prolonged QRSs. And it's legal to have a bundle branch block and an AV block at the same time. Okay. On the test, no, I'm not going to give you that as well. But usually on the test, if you have a wide QRS, it probably means idioventricular, which we'll talk about, or it means that you have a third degree AV block. Okay. But in this case, we have a second degree type 2 or 1. Which one is it? Type 1. Why is it type 1 and not type 2? Because we have longer PR intervals. That's the key difference between second degree type 1s and type 2s. The only difference, really. All right, so number 13, what is that? That looks irregular, you just look at it and look away, look at it, look away. That's just irregular, right? It's going, right, it's not a commercial. Anyways, you're going to look at it and you're going to see an irregular rhythm. I got something going on here and something going on here, right? Was it longer dropped, or was it just, ooh, drop, where'd they go? They just ghosted me. Left me on red, right? So what is that? Second degree type 2, because the PR intervals are consistent or the same, right? So, but it's not greater than 0.20. That's one of the little asterisks. Not always it had to be greater than 0.20. It's just you have a drop QRS, right? And it wasn't, you didn't see it coming. That is a second degree type 2, right? And what about number 14? What is that? Why is that third degree? Because these dots are giving it away. That's our P wave. That's our P to P interval, right? It's doing its own thing. And look, it made that T wave even higher because it added its little positive P wave to the T wave, right? Normal T wave was over here, right? When you put them on top of each other, it's going to be a little additive. So all you got a wide QRS there is kind of cluing me into a third degree AV block. What else tells me it's a third degree AV block? I got a ridiculous PR interval, right? The PR interval, look at this PR interval right here. That's ridiculous, right? That's a ridiculous PR interval. Also, there is AV association or dissociation? AV dissociation. Okay, so a third degree AV block. What about number 15 up top? Top right. I have P wave. Whoa, why is the P wave after the QRS? That's a problem, right? It's like you might think they're associated there, but if you look at the QRSs, that's the regular rhythm, right? It doesn't look irregular at all. It looks like there's nice and even QRSs, nice and even P waves. If you march them out, you got the P wave after the QRS. This is a what? It's a third degree AV block. Number 16, what is that? It says 0.36 on my PR interval. It's greater than a big box. So why does it first degree, not third degree? Because third degrees have disassociation. Third degrees usually have a prolonged QRS, but we know that sometimes patients can have prolonged QRSs for other reasons. But the other thing is we have P wave QRS, right? P wave QRS, P wave QRS, P wave QRS. There's no P waves adding themselves to T waves. There's no P waves that are in weird spots as well. And the PR interval is not ridiculous. 0.31, 0.36 is getting there, but it's not quite ridiculous enough. So it's a first degree AV block. What about number 17? Again, on your test, you're not going to have little dots that tell you where the P waves are. All right, this is for learning purposes only. All right, you can see this PR interval is not ridiculous, but this one is. That is a ridiculous PR interval. That is a huge, you got 1, 2, 3, 4 boxes, right? What is that? It's like 0.80, right? That's a huge PR interval. That is what people call ridiculous. So a ridiculous PR interval, we don't have any kind of association as well, right? You could say, oh, maybe there's like drop complexes. Maybe that's what's going on. But it looks like a regular rhythm to you, doesn't it? Does it look irregular if you just like glance at it? I mean, that's irregular. If you look at the one down here, this one looks irregular, right? They got something going on there, something going on there, something going on there. But this one's nice and regular. Look how regular that is. If I get my calipers out, I can measure it. Oh, look at that. My R interval is 0.8 or 1.2, let's say. We can actually measure the big boxes, but you can see that that is a normal thing. Okay, a normal rhythm, or normal, not a sinus rhythm, but a third degree AV block. What about 18? Right, we got some dropped complexes here. We got an irregular rhythm, drop complexes. Did we see it coming? Did the PR interval get longer, or the PR interval was the same? PR interval is the same, and it just dropped all of a sudden, right? So that is second degree type 2. What's going on there? That looks irregular or regular? It looks irregular. So if it's irregular, that means it's a second degree block of some sort. So is it a type 1 or type 2? How do you know it's type 2, not type 1? PR intervals are the same. Were they getting longer drop, or are they the same? They're the same every time. So that is a second degree type 2. And you got a bundle branch block too. That's like, well, I got wide QRS. That must mean I have a third degree. But that's something that patients can also have. All right, number 20, what is that?
Third degree.
Third degree, why is it third degree?
Divorce.
They're divorced. Also, this is a regular rhythm here. Nice and regular. I only got 2 complexes to speak about, but they are regular. Okay, so, and I got P waves, they're doing their own thing, separate than the QRSs. So that is a third degree AV block. What about 21? What is it? Yeah, it looks like first degree. Why is it not second degree? Because it's regular. For one, there's no drop QRSs, because if I have a drop QRS, that makes it irregular. So I got a prolonged PR interval, and are they divorced or are they together? They're together. I got P wave QRS, P wave QRS, P wave QRS. No, P waves doing their own thing instead of ST segments are on top of T waves. Okay, and they got a bundle branch block to write home about as well. What about the bottom one there? What is it? I got a 0.28 QRS, PR interval, and this looks pretty regular to me. So that means I got what going on? We've got P waves followed by QRSs. Yeah, every single one follows a QRS, right? The PR interval is the same every single time. If third degree blocks, they're not the same every time, right? So that's a first degree AV block. And they got a bundle branch block too. Number 23 does not have a bundle branch block. The QRS is less than 0.12. So what is 23? We got a drop QRS there, but that means we have a second degree. Is it type 1 or type 2? So we got QRS or PR interval that's getting longer dropped or not? Yeah, it got longer from here to here, right? So that PR interval in the first complex was X amount. You can measure it. We got time, but you can see that it's getting longer, and then we got drop complexes. Therefore, it's a second degree type 1. All right. What about 24? So you got PR interval that's 0.25. I have no drop complexes. I got P QRS, P QRS, P QRS. Therefore, it is a first degree AV block. Remember, that's just flavor. So we have to add it on top of our regular rhythm, which is what? Is that Brady or tachy or normal? It's Brady, right? So sinus Brady, the first degree AV block. What about 25? So we got P waves doing their own thing, but is it, they could be drop complexes in there. Is it drop complexes or not? No, because look how nice and regular this is. That's where you measure the R to R and the P to P, right, interval, and you can see that they are different, right? So that if they're different, that means they're dissociated. Also, if you have a regular rhythm, that just rules out and says it's impossible for it to be a second degree at that point. Right, so we don't have drop complexes in this situation. This is a third degree AV block. What about the last one there, number 26? So we got a P wave QRS, P wave QRS, and P wave nothing, right? Well, could that be a third degree AV block? This looks like the exact one right up top, but what's the difference? Look how irregular this is, right? I got a drop complex there and there and there. I got randomly dropped complexes. Did I see it coming? Was it longer drop? No, it was a second degree type 2. And they got a bundle branch block, and they got ST depression too.